welcome to Rocket Rounds. In today's episode, I'm welcoming Dr. Matt Follwell, radiation oncologist and chief of oncology. Matt, like many physicians, has had to switch to more virtual care during the pandemic and the challenges of seeing patients face to face. So today, we're going to ask Matt about virtual care and how to optimize virtual visits. Welcome, Matt.
Thanks, Chris. Thanks for the opportunity.
Okay, so Dr. Follwell, how are you integrating virtual care into your workflow? You got a busy clinic.
Essentially, when things started to lock down a year ago, we were trying to keep as few people coming into the center as possible. Essentially, anyone that doesn't need a physical exam, we're doing virtually, whether that's telephone, OTN, through our pcbc system, or the ones that we do have to see in person. We got our traffic down probably to about 20% of what it was prior, meaning 80% of our visits went virtual almost overnight.
Well, 80% virtual. And are these kind of those synchronous or timed visits where you're live talking to the patient?
Try to. We started off trying to be relatively rigid in that, booking patients every 15 minutes, for example. Patients are often not necessarily available at the time that we've told them, so we've gone to saying, please be around within about 2 hours of the set time. We'll try and stick with that time best we can, but obviously through a busy clinic, that's not always possible. Most of the time we're trying to batch visits so that you'll have, say, 3 or 4 virtual visits mixed in with one in person so that we can have still some flow, but every provider is different based on the population that they're treating, the disease sites that they do treat. Me, for example, I'll do primary brain treatments, GI cancers. So the main people that I brought in were those that needed physical exams in terms of ruling out recurrences and follow-up of toxicities from their treatment.
Right, so those are the pieces you need to see in person, examine them, have a look at them, and everyone else, though, you're able to do this online.
Yeah.
Now that's the kind of the synchronous one. How do you find that works?
I think it's great, actually. Depending on how busy a clinic day, and I've already had someone booked, say for my follow-up day on Thursday, I'll try and work ahead even a couple days. It's not always possible, and one of the bigger issues is doing phone calls. We try and block our number so that patients don't have our number unless really need it. So they often will just see an unknown caller and then not answer. So I do a lot of my calls from the hospital line, so at least it'll come up as the RVH, which seems to work better for the way that I do it. Do phone calls, say a few days ahead, opens up space for that follow-up clinic the couple days after. Most of them, as opposed to working virtually or remotely from home, we'll do almost all of my virtual visits from my office. Or from one of our OTN rooms where it's already set up with the computer and with the OTN equipment.
Got it. I'm going to come back to the question about hardware and software, but what I wanted to ask is, how do you make the visit professional? Because when someone comes into your office at the cancer center, you're in a physician's office. It's legit, professional. How do you maintain that professionalism when it's virtual?
Well, I think it's a very good point, because I think not just our follow-up visits, but we also have new patient consultations, and some of those are moving to have moved to virtual means. It's always nice when you can be able to see somebody, so try to have those as one of the pcbc virtual conferences to start with. Yeah, you try to have a similar routine that you go through just as if someone was walking into your office. Obviously on the telephone you don't have that kind of visual cue that you would. Again, if it's somebody that I hadn't met before, go through number one, that they provided consent to proceed along virtual lines. We try and have anybody that we know is going to be a virtual visit, have our clerical staff inform them, ask if this is okay to proceed with a virtual visit. So we get that consent up front. Okay. But I do make sure that I go back on that before we start talking. Make sure it's the right person, obviously. Not checking ID or anything like that, but generally it's just taking them as their word that that's the person that I'm supposed to be talking to.
Fair enough. And all those kind of good safety issues, as you said, with confidentiality, is it consent, is it the right person identification? Mm-hmm. If you're wondering, there's a good virtual care playbook the CMA's produced, which kind of goes through kind of some of the stuff that Dr. Follwell was talking about today. So that's great, Matt. So what about asynchronous virtual visits, which are like emails, so stuff that you can communicate back and forth but aren't real time? Do you use that in your practice?
Not very often, rarely. We do have a group email, so if we send something out, it doesn't necessarily come from my personal RVH email. We have been taking patients' emails proactively, so when they register for the new patient visit, just so we can provide electronic information, for example. If they're going through a course of radiation to one area of the body or the other, we have electronic pamphlets that talk about what side effects are, what to do if you get into trouble, and how to manage certain side effects. So we're using that more as an education sort of flow as opposed to dealing with clinical issues.
Got it. It sounds like the Cancer Center, you got quite an organization for this. This isn't just turning on your computer and doing it. It sounds like it's a system that's been built to operate at fairly high efficiency and fairly large number of patients.
Yeah. So as part of the cancer program, we have a group called Prevention and Screening, which do most of our patient-facing education. So we have dedicated staff and project managers that look at best ways to get information out, make sure all our information we're putting out is up to date, and that we're continually refreshing that as we go.
And is there someone for your clinical one-on-one visits with patients, is there someone setting up that call for you, making sure the patient's online, ready for you so that you can kind of walk in and get going?
If we do that through the OTN, so OTN also has hubs at different hospitals, so like Collingwood, Huntsville, Aurelia, so that does often will have a nurse present. Those are mainly for our pre-chemo visits where you need a physical interaction, physical assessment, and blood work and that sort of thing. So if we're doing it through the actual OTN center that we have, that is set up ahead of time, meaning making sure the patient's getting there in the right place so that they're set up for the actual call. If I'm doing it, it's using the PCBC system, which is through OTN Hub, but essentially someone had booked that appointment, given the patient the contact and the link so that they can access a PCBC. If it's telephone calls, they just are told, be here in and around this time, Dr. Follwell will call you.
So Matt, we've used a lot of acronyms, OTN, PCBC, just for some of the viewers, what do those stand for?
So OTN is the Ontario Telemedicine Network, and PCBC is Personal Computer Video Conferencing.
Got it. And those are the OTNs that kind of the gold standard in terms of encryption. I know we use it for trauma, for stroke. So that's probably your best. I think Teams is also legit in terms of safety for confidentiality, but something like Zoom, FaceTime isn't PHIPAA compliant. If you're not sure, please make sure you check with your privacy officer, your hospital, and your IT department to make sure that you're meeting the requirements for patient privacy. All right, so what we're going to do now is I want to ask about kind of hardware and stuff, because you just can't use your Gmail or FaceTime patients. There are certain things for privacy concerns. So let's talk about hardware, like the physical stuff you need. What do you use to communicate? Do you use your laptop, your phone? How's your setup?
So with the actual OTN hubs, there are specific video conferencing equipment and things like that. In my office, just a regular desktop and a camera.
Got it. Okay, so you got a desktop. Okay, good.
But staff, or the physicians and other staff that are using these for virtual visits can do them from their home as well, home laptops, things like that. We obviously have to go in through the OTN hub itself is just a website, so it's not necessarily even within the server here at RVH. It's not necessarily a firewalled thing, but it's got its own encryption. So as opposed to things like Zoom and even Teams, it's a much more secure way of communicating.
What about texting patients?
I don't do it personally.
Is it? I think that's probably not advised. I don't know whether that's a thing or not.
I think it's probably more about, what would I say? I think it's more of a kind of, I would say more a boundary area issue sometimes, because I think it's legal and doable. Obviously, if you're in the circle of care, it's the same as if you'd have a telephone conversation with them. To my knowledge, at least, I think it's more just I try and maintain those barriers as best I can. So I don't necessarily talk much about anything clinical, i.e. sometimes for my primary brain tumor patients that don't necessarily have the insight, I will communicate once in a while with family members that I know are at a bit of higher need in terms of providing really quick guidance, clinical guidance to people if they need it, but I rarely give out my own cell phone.
Yeah, fair enough. And I love to talk to some of my family medicine colleagues to see what their practice is with that. Okay, so really quick, I want you to walk me through kind of a step-by-step how you do a virtual visit. So let's pretend I'm not across the table from you, and we're having a virtual visit. I've never met you. So your colleague has already gotten consent that I understand virtual visit. So I've signed on. I figure the program.
Yeah. So when we're using the PCBC or the OTN hub, essentially just start the discussion with the patient, introduce myself or reintroduce myself if I've known them already. Essentially say this is likely how long we're going to be spending today, because we do have to document with all these virtual visits the amount of time that you are spending on the actual visit. Go into why we're meeting together. If it's a new patient consultation, do a brief summary of the information we know, allow the patient to be able to provide information about their clinical situation. Then obviously we don't examine people. You can sometimes have, if they're in a space where they can, so like surgical scars, things like that, like for breast cancer and things, just to make sure things are healed up enough if possible that we can start the radiation planning, things like that. Toxicity wise, you can make sure that things are healing properly and follow-ups. Go through that kind of thing, essentially the same layout as I would any kind of consultation. Try and summarize things best you can at the end, and then leave them with the next steps in their care as you're going forward.
And how do you document after the visit?
So all of ours, we have to document any of these virtual visits just the same as if they're in person. So we use the dictation system that we have through the hospital and transcription. Try and do them immediately after while things are fresh. In terms of just your workflow, some people do them batches, depending on what their day-to-day looks like and what their busyness in terms of how many people they have to go through in their follow-up clinic, for example. New patient consultations and try to do right afterwards just to make sure things are fresh and the discussion are in mind.
Got it, absolutely. And I know for medical legally, the CPSO are revising their kind of policy on telemedicine. It was last done in 2014, and I know the baseline is, though, essentially virtual visits should be held to the same standard as in-person visits in terms of professionalism, communication, all the standards that we have day to day. Great. And what do patients think about this? I mean, it sounds like it's working for you. How's it working for the patients?
I'd say the vast majority are very happy to do it that way. Outside of just COVID and wanting to reduce the number of people coming, we have people that come from essentially Parry Sound to over like halfway to Peterborough, halfway down to Newmarket, Orangeville, Owen Sound. Vast majority, especially in the wintertime, don't want to be on the road.
Yep.
Financially, it's a burden on people sometimes in terms of literally paying for gas to be able to come here, and some just aren't as mobile. So the vast majority, I would say, are very pleased to be doing virtual visits.
Yeah, who wants to take a day off work, pay for parking, as you said, drive in bad weather. So It makes sense, and I think that I would want that if I didn't have to be here. I think there's certain visits, there's nice to be face-to-face and to talk to someone, but I think especially the video adding that body, you see body language, you can see people's expressions, adds a lot.
Well, and you can get a picture of their actual environment, home environment too, which is helpful sometimes. So you can often have family members there that wouldn't necessarily be able to come in with them for in-person visits. So we do have some barriers that way in terms of making sure people have enough supports and always have another set of ears essentially going through some of the discussion, especially for new patient consultations.
Sure. Okay, so I want some hints, some Dr. Follwell hints on how to do really good virtual visits.
Well, I think it's just following a lot of the things in that playbook, to tell you the truth. It's making sure that you have your medical legal things ducks in a row. Make sure the consent has been covered and that you always have to kind of keep that at top of mind. I would say the more you can do, the kind of better you get at it, truthfully. Certain things does never replace an in-person visit, though, in terms of what physical exams you need to do for the ones you do. I think it's just something that you kind of get the hang of a little bit the more you do. Especially the virtual video conferences, I think, are really quite helpful as well. There's some technical glitches that are associated with that, depending on the age of your population and their comfort level with actually using computers. But you'd be quite surprised that even the 80-year-olds can get the hang of it pretty quick. I think it's just finding what balance works for you. So if you know that you have to have a certain amount of in-person visits versus that are not going to change, how you mix in that kind of population of virtual visits, if you want to do a whole morning or a set block of virtual visits, set block of video visits and phone visits, and then have in-person. It really depends on what your workflow is. And I think the flexibility of being able to do that and not having something that's so rigid, i.e. I have to see every single person on a certain amount of time, setting those expectations with the patient to say, listen, it's kind of like the cable company. I'm going to give you a 3-hour block where you have to be there. They'll expect that. They know to expect you. They're not worried if you're 15 or 20 minutes late or an hour from what the set time was. So I think setting up with some flexibility really helps that portion too.
Good. So that's awesome. Those are great hints, especially the flexibility one, because then patients, again, you set their expectations so that they don't feel like they're being left. If you need more information, we're gonna post this link for this virtual care playbook, as well as Health Quality Ontario has another kind of document on adopting and integrating virtual care in your practice. I'd like to thank Dr. Follwell for a great talk. This is, I think, going to be becoming fairly standard in most people's practice even after the pandemic improves. So thanks for your expertise and your guidance.
My pleasure. Anytime.